UNAIDS estimates that from 2002 to 2012, expanded access to HIV treatment averted 4.2 million deaths globally and contributed to a 58% reduction in new HIV infections. The International AIDS Conference took place in Durban, South Africa this year, where scientists, policymakers, world leaders, and people living with HIV gathered to share best practices, learn from one another's experience, and develop new strategies and collaborations. Over the 5-day event, there were numerous sessions focusing on everything from the latest issues in HIV science, policy and practice, key research findings, as well as identifying gaps in knowledge. One of these sessions looked at private sector engagement, friend or foe of Big D development. Before we find out more about this session, let's take a closer look at some of the organizations being represented on the panel.
there's clearly no need for me to introduce what is clearly an eminently qualified and distinguished panel of guests. The objective, given the time that we have today, is really to share some of the thinking on the role that the private sector could play in ensuring access to medicines and commodities, but also in developing efficient, effective, and sustainable supply chains. Perhaps I'll start with Nevin for some opening comments. We'd then like to open up the discussion once we've had initial comments from the panel, and have a useful and worthy discourse.
I'm the CEO of Cipla Quality Chemicals, a manufacturing company based in Kampala in Uganda. The company was established in 2009 and to date has had a capital investment of roughly $75 million. It's one of the few WHO, World Health Organization, approved facilities in sub-Saharan Africa, and is one of the even fewer factories producing a range of World Health Organization pre-qualified ARVs and an ACT for the treatment of malaria. In addition, it also manufactures a range of drugs for the treatment of hepatitis B and shortly for the treatment of hepatitis C. We estimate that last year about 250,000 patients in Uganda were stabilized on antiretroviral therapies manufactured by Cipla Quality Chemicals in Uganda. And last year, we produced around 20 million treatments or doses for malaria. The company exports to 9 countries in sub-Saharan Africa, ranging from South Sudan to Namibia to Zambia, Comoros Islands, as well as more locally in East Africa to Kenya and Tanzania. It's a supplier of ACTs or anti-malarial medicines to the Global Fund, as well as to some of the countries that I've just mentioned. The key issue from our perspective is that 80% of the world's malaria cases and more than 70% of the world's HIV cases are in Africa. But we know that less than 2% of the ARV medicines used to treat these HIV patients in Africa are actually manufactured in Africa outside of South Africa. So we have a situation in Africa where less than 2% or 1 in 50 of the medicines being diagnosed and prescribed for the treatment of HIV, AIDS, are actually manufactured in sub-Saharan Africa outside of South Africa. And this inevitably raises questions about the sustainability and security of supply, not only of HIV/AIDS medications, but also more broadly of malaria, ACT medications, and others across the pharmaceutical spectrum. Self-sufficiency in pharmaceutical production is a hot topic in Africa. How do we improve the availability of quality, locally manufactured pharmaceutical products in sub-Saharan Africa, not only for the treatment of HIV, AIDS and malaria, but for other chronic conditions such as hepatitis and many of the tropical diseases, which to a certain extent are, it would be fair to say, somewhat neglected currently. These are some of the topics that we'd like to raise with you and discuss with you in more detail over the course of the next 30, 40 minutes. Thank you.
Abraham, could we ask you to make some opening comments?
Thank you. Pyramid Pharma was founded in 2001, and we have grown to be in 6 African countries. We are mostly distributing healthcare products, that is pharmaceuticals and medical supplies, also medical equipment. We are representing some of the world-renowned companies in HIV/AIDS, including Mylan, BD, Sysmex, Human. In East Africa, we work very closely with local government, and East Africa and Southern Africa. So we work in Rwanda, Burundi, Kenya, Uganda, Tanzania, and Mozambique, and Ethiopia. We employ close to 350 people in those countries. We work with a lot of local implementing partners in making sure that patients get access to medicine. Also, we do a lot of work on regulatory to ensure that patients and governments get access to the most recommended medication by WHO, so we ensure that medicine gets registered.
Thank you very much, Abraham. Ian?
Yeah, thanks, Shabir. I think the role that Imperial plays in terms of pharmaceutical warehousing and distribution across the continent is reasonably well known, but I don't know that anybody from either our public health client base or our commercial client base know about the other side, so it's still worth going through it. Yeah, we have both logistics businesses, logistics operations businesses, as well as trading entities in the markets and represented in all the major markets, moving about 27 million packs of medicine every month free between manufacturers and points of care. And so within the public health arena, we'll run warehousing and transportation services down to last mile delivery to, for example, 5,000 delivery points across Nigeria in the public sector. But in the same country, we have a separate business that's got about a 75% market share in the trading environment of pharmaceuticals, an innovative product. And where the biggest business is, in fact, in West Africa, obviously South Africa is a big part of the business as well. And there we have both commercial operations where we trade, but also logistics service businesses where we just provide warehousing and distribution capacity. What's been really interesting is to see how over the last 10 years we've been able to expand that business into different markets and use one client in order to try and build out the business in these different environments. And the anchor tenant, if you like, of that strategy was in fact USAID. And we were successful in working with USAID since 2005 when we opened the first facility in East Africa. And we're now at a situation where we've got a business just in the healthcare division of Imperial that employs 282 people, and it's got a revenue base of $115 million a year. And but when you get into the weeds of that, that's where it gets really interesting. And so the salaries that we are paying is $19 million a year of the people that we employ. We're paying about $9 million a year in tax to the governments of the countries in which we operate. And that's in both pay-as-you-earn taxation for the staff as well as for the company tax. We invested over $8 million in the last 12 months in capital equipment and facilities, and so, which is probably as much, if not more, than many of the governments we work with. And then probably the most important one, we spent $43 million on services with third-party organizations, with other transporters and other service providers in these markets who are locally owned enterprises, who have their own businesses and are looking to do their own development of their organization. And so the point of the story is that working with a single client, but continually reinvesting in the business, we've been able to scale to where we've developed that level of intrinsic sustainability. And so for me, there's two big issues that we like to debate in this kind of thing, is saying, how do we get other organizations, donors, and governments to see the private sector as the primary place to work? So instead of the government spending their money as an investor by buying warehouses or trucks, spend it as a customer. Buy services from people who have trucks, or buy services from people who have warehouses, because those people, by their very nature, will continue to invest in that capacity and continue to invest in the people that they've got in those businesses. The first one is that, how do we get that movement to invest as stop spending as an investor and spend as a customer. And then the second one is the concept of buy local. As many of you know, we've had great success in working with locally owned transport companies. And so instead of defaulting to the big brand internationals, working with local folks to help them invest in their people, in their systems, in their skills, and in their security systems as well, and to encourage them to keep growing their ability to serve not only healthcare, but other places in logistics as well. And I even extend that through to purchasing from the local wholesalers, where there's an opportunity to actually use the spend to create an economy of scale in these markets. Wholesaling is a natural oligopoly. You're naturally in the developed world, you see a condensation of the number of service providers in a market from the 400 that we would have in a Zambia down to the 3 that you have with 85% market share in the United States. And so in the developed world, a natural oligopoly develops so that people are able to develop the economies of scale in order to make returns out of the level of investment that pharmaceutical distribution requires. So that's my opening gambit. It says, how do we get that transition in headspace that says, work with the private sector and leverage their natural appetite to invest and continually grow? And how do we look at ways in which we can further develop local business by buying locally in terms of product procurement?
I guess some would argue that there's evidence for this being a successful model in other sectors, in other industries. In fact, some would probably call it Uberizing the supply chain. I know Ian probably would lean towards that. But it'll be good to take that thread further as well. But I'd like to welcome Dr. Mark Dybel. Thank you so much for joining us. Mark has clearly no need for an introduction. But I'll remind the audience that Dr. Dybel is the current Executive Director for the Global Fund, with, again, years of experience in HIV and in public health. Mark has also served as a clinician supporting implementation of programs, as a scientist in key research areas, and of course, as a teacher, an ambassador, and an administrator. Welcome, Mark. I'm just wondering whether we'd be able to ask you for some introductory remarks.
So, I would break it down into a couple buckets, and I don't think, first of all, we've recognized the role of the private sector the way we should. So when the Global Fund was created, and even when we were at PEPFAR, there's this fantasy that the private sector is going to come in and donate billions of dollars to global institutions and funds. It was a nice hope, but it's fantasy. I mean, companies don't have money like that, and their shareholders would probably fire them if they used it that way. So where can the private sector play key roles? And I would divide them into service delivery and advocacy. So, and technical support, which relates to the service delivery. So let's start with advocacy, because I actually think this is an area we have not spent enough time on. So, when global health types like me go around to heads of state and tries to get a meeting with the Minister of Finance, which is not so easy to do, of course they listen, for the 5 minutes that we have or 15 minutes that we have, but then they usher us out the door and they bring in someone who's advocating for education or advocating for nutrition, all of which are important. It's very different when the private sector goes in and says, look, we need healthy, educated people if we're going to have employees and to buy our stuff, because they have to have an income. And when I've talked with CEOs about this, they all say, of course, companies have been doing this for centuries, literally centuries, trying to push more healthy, and better educated people so that they can function, because that's what actually generates economies, and that these issues matter. let me give you a concrete example. It's pretty hard to convince a CEO to invest in a country where a third of its workforce is out during the malaria season. Why would you do that? Or to convince your board of directors that you're going to train someone for 15 years to get to a hyper efficient and effective level, and then they're going to get HIV and die, and then you're going to have to start all over again. You know, health and education drives economies, it drives economic growth, and we've not actually engaged enough with the private sector on the advocacy front. And that's particularly true in countries that are growing economically, because are trying to grow economically, the countries where we work, because they actually need jobs. They need that foreign direct investment, and they need the engagement of the local companies, which we often overlook and go to multilaterals. And those chambers of commerce and those CEOs have access that global health people, global development people will never have, and you have a voice that none of us will have. Now, I know it's difficult, and particularly a concession from the country, and you don't want to push too hard, but this is a key role that's essential for the long-term effort. So I would actually put advocacy up there with as one of the fundamental roles of the private sector where we align, where we're totally aligned, because health is important for the functioning of the companies. The second one would be technical support. So again, expecting companies to give billions of dollars isn't going to happen, but both for their own internal retention, but also for their own engagement in countries where they have interest, and that's the key. You don't ask a company that has zero engagement from a business perspective in a country to go do something in a country. It doesn't work for them, unless they want to go there at some point. And focus on the pieces that are the company's core competency. So don't ask them to engage in something that has nothing to do with what they do on a regular basis. So as an example, and we use this all the time because it's a great example actually, is Coca-Cola and supply chain. Now the first idea people had with Coca-Cola was actually crazy. It was like, oh, let's throw some condoms and some antiretrovirals on trucks. Well, that's not a very smart thing to do. But they have enormous competence, so you can take them, and that's what we've done, and embed them with a Ministry of Health and have their supply chain people supporting the ministry to develop their supply chain. And that worked in Tanzania to begin with, and now we're expanding to 9 or 10 countries. And the COO of the company is hyper excited about it, president and COO. And it's good because they're using their core competency, they're using their people, and it's great for retention because more and more companies are being challenged by their workers to say, how are you engaging in social areas? And the third is actually doing stuff and being financed to do stuff, either from the government or from external financiers, or ideally both. And here supply chain, I think, is one of the best examples. I mean, the public sector is great at a lot of stuff. The public sector is not good at, in general, procurement, supply chain, and oversight of program quality. They need support. These are things the private sector does exquisitely well. It's project management for program quality. It's project management and development of supply chain. It's project management and development of procurement systems. And so I think we've seen some great successes. I think the work Ian does is a great example of that. I mean, in Tanzania, they actually made basically a quasi-private sector organization. In Kenya, they have KEMSA, which is a non-governmental, but linked to and does exceptionally well from a supply chain perspective. I don't think we've been smart enough about advocating with governments on why they should be funding the private sector to do this work. Part of it is a greater value for money, and part of it is just jobs. So one of the things that drives me crazy, well, I shouldn't say that, because I do think we need local production of commodities in Africa, and Asia, and Latin America. But it needs to be regionalized for it to be viable. But the number of heads of state I talk to and ministers of finance are like, oh, we need a factory for this. A factory produces 200 jobs. A to Z in Tanzania produces 200 jobs. When I ask heads of state that, I'm like, how many jobs do you think you're going to get from that factory? They're, oh, tens of thousands. No, it's 200 jobs. A supply chain is literally tens of thousands of jobs. And this is where I think the regional development banks come into play, because they do infrastructure and they do well, what more infrastructure is there than a supply chain? And if we're going to achieve our global health goals, we need a supply chain that gets down to the village level. And so I think from a on-the-ground delivery mechanism, again, focus on things the private sector does well. Don't expect the private sector to build a human rights campaign. I mean, that's not what we would generally go to the private sector for. Go to the private sector for the areas where they are incredibly expert at, and build the business case for why a government should invest there. Related to that is where healthcare occurs in middle-income countries. And it's a mix, but it's heavily the non-public sector, especially for the middle-class people or the middle-upper-class people. So South Africa is a great example of that. Indonesia, India, Nigeria. 80% of people, when they go for malaria treatment in Nigeria, go to a kiosk. They don't go to the public sector, and we have the wrong drugs there. In Indonesia and India, especially Indonesia, Nigeria, Ghana, we're seeing an increase in the rates of TB, frightening increase in the rates of tuberculosis. And it's because the public sector actually has great programs. They have 80 to 90% cure rates. It's just who gets into the public sector. In the private sector, people don't use chest x-rays. Local physicians don't do chest x-rays. We're missing an enormous amount of tuberculosis, and that's why we have these increase in rates, even though we have good public sector programs. So the service delivery is in part the procurement supply chain, but it's also where people go for healthcare. And if we don't strengthen those sectors, we can't possibly achieve the global health objective. So, I mean, that's a long answer, but I think, people try to go to one or this little piece or that. It's actually a comprehensive whole. I'm not even touching on all of it for engagement of the private sector. And if we're smart and if we do it well and if we work together, we can actually solve these big problems. If we try to compartmentalize and say you should do this or that, or we're not only are we dead as a global health community, the people we're supposed to serve are dead, literally.
Absolutely. If we work together and we do it well, we can solve these problems.
More on the role the private sector plays in ensuring access to healthcare after the break.
I think now's the best time to sort of open this up for questions and perhaps even comment from the audience. I'd also like to invite the panel to ask questions of other members of the panel, if you like. Could we open this up and get some questions? Ian?
We went down the road of how much we've invested into our businesses. And simplistically, if you look at the volume and order of magnitude of investment that's required, how simple has it been for you to get capital? Is capital freely available? With a listed entity, I guess it's probably easier. I know in the quality chemicals days before CIPLA, it probably was a completely different picture to now.
Yeah. It was quite difficult in the early days. Building a greenfield pharmaceutical manufacturing plant takes several years, from groundbreaking to actually producing the first commercial batches. And in the case of quality chemicals, that was getting on for between 3 and 4 years. So there's quite a long time frame from when you make the first initial investment to when actually, of course, revenue starts to flow in. And whilst the original investors in the company ploughed money into the company, because the time frame was that long, it will be fair to say there was a cash flow crunch. What enabled the project to come to fruition was an initial investment by the Ugandan government of a 25% stake in the company, which enabled the company to complete the construction project. Subsequent upon that, finance became a lot easier, and the rest of the project was completed with the aid of a bank loan, which was freely granted, which is now completely paid off, and the company is debt-free. But I think it would be fair to say that without that initial, as it were, public-private partnership between the company and the government of Uganda, things would have been quite difficult. And it was that public-private partnership, in a sense, the government of Uganda putting its money into the company and putting its money where its commitment was, that enabled the company to get where it is today. Subsequently, the stake has been sold, and there is no government funding for the company in terms of shareholding. The government has no equity now, yeah. Yeah.
So, thank you. I first, for very excellent remarks. I'm from Tanzania, so it was honor to hear so much about Tanzania good work. To answer your question, maybe I wanted to also add some comments. Some of the work that we have done in country had required substantial investment, and we were decided later, because of private-public partnership, we were approached by USAID and MSH to do a malaria campaign, which for the adults. So we decided at that time, when the project was expanding, we got an private equity investor to invest into the company in order to undertake this project. Yeah, and afterwards, the project with USAID didn't come to fruition as to what we would have liked, but it had allowed us to set a stage for great work that had to come later. So we invested heavily into getting personnel first to put our company into greater shape, yeah. And the initiative that we had for MSH and for the accredited drug dispensing outlet later led to malaria medicine being distributed on a co-funding by Global Fund. And we also did some work on distribution of, also for co-funding for the test kit of malaria, which has reduced overuse of malaria drugs. Yeah. So getting capital in the beginning was a very difficult subject. We had to sell equity in the company to get the private equity, yeah, to invest. And afterwards, the current work we are doing, which is what I had planned initially to ask from the Global Fund, yeah, is mostly on diagnostics in government. So Global Fund is doing, or is investing heavily into diagnostics. So for CD4, they are buying a lot of tests, and they are putting a lot of money into government to procure these tests. And I believe at a fraction of what they are currently paying or through the government, they could have got a service from private sector. He had said the government will not fund the private sector. So we really don't need the government to either fund, but to provide the contracts for which we could leverage, provide jobs, also buy services from the private sector. So part of the Coca-Cola work you are doing in Tanzania, which is a very good model, they could also do the same for diagnostics. I believe the core function of the companies, like you put, for example, Roche, Abbott, BD, they will do it much more efficiently if you had gone to them and buy a test than currently through the funding mechanism that the government is, Global Fund is giving money to the government, and the government is procuring, and I don't think you're getting money worth of at the end of the dollar you are putting in. So I would strongly ask Global Fund to engage in each of the countries that are working with private sector. I know they are doing a lot of work with NGO, but there is no engagement with private sector in each individual country, and to try to see that these services, we have done a lot of investment over the years with the government, can we at least a portion of that services now decide to do it in with private sector? I'll give an example of work that we are currently doing is USAID. They have decided to buy a test from us at a fixed price over 1 year period. So they have gone to an implementing partner, a local implementing partner, put up a tender and said, okay, we want in these regions, which is highly regions which are HIV is highly prevalent, decided to buy a test and measure it over a period of 1 year. So the work has been very successful, and they also want to propose the government to adopt.
So the private sector actually is where we buy everything from. It's where the government buys everything from. You actually have to win a contract. So it's not our job to win contracts for you. Everything they buy is from the private sector. There's no public sector creation of, you know, test kits. So you have to win the contracts. So the key, and I think to your question, Ian, is what does a company need to be viable? So, you know, Quality Chemicals does great work, and I've seen your factory, and you almost went out of business because you didn't have someone to invest.
Yeah.
A very high quality antiretroviral manufacturer in Zambia went out of business because they didn't have a market. A Guyanese company couldn't get off the ground. Why couldn't they find investors? They couldn't find investors because they didn't have a business case for a market, which is not a set-aside for a company because you have to win a contract. It's actually a market. So how do you access a market? So we couldn't even get someone, in the case of Guyana, to spend $350,000 to do a bioequivalency test, because they said, where's your market? I'm never going to recover $350,000, because you have to go country by country, you have to work on the tenders, you have to follow the tenders, you have to work with the government, you have to go through the regulatory authorities, you have to do all this stuff. And how are you going to compete with the big companies that can do all of that? And set-asides are never going to happen, and you have to have the right pricing, and you have to have the right quality, and you have to do a whole bunch of other things. But how would you solve that problem? So one of the first thing we did is a pooled procurement mechanism. And we can't force countries to do anything. That would violate the very foundations of our organization, which is country ownership. So we can't go to a country and say, you will or buy this or that. We'd be kicked out of the country. And it would violate our principles. But we did create a pooled mechanism because volume matters. If you have volume, you have market, and you have access to a market. So within the course of the last 3 years, by doing that and by directly negotiating contracts at volume and taking out middle negotiators, so in the case of antiretrovirals, we worked with PEPFAR, we worked with the government of South Africa because they buy, you know, 2 million to 2.5 million doses a year for people. And that way we went from a small share of the market to 80% of the market, and then you can do volume. We did the same with bed nets, and we brought UNICEF, the United Kingdom, and the US President's Malaria Initiative together. Did direct negotiation, dropped the price by 40%. But the challenge was, what happens when a country can't use pooled procurement because they're no longer part of the Global Fund procurement anymore? So we went from about $300 million under management from the pooled procurement mechanism to $1.2 billion under management of the pooled procurement mechanism, because countries started to seeing that they could actually save money. So even Rwanda used that mechanism, and you know how protective they are of their, as they should be, of their procurement system, because they could save $20 million on bed nets and fill their bed net gap. So countries increasingly opted for this mechanism because they get better prices, but then what happens? They haven't built a procurement system, they're just buying through one. So we created something called wambo.org, which is an amazing tool. It's actually an online pooled procurement mechanism. And any company that meets quality standards will automatically have access to a global market, which will solve the problem in many ways of why would you invest in, how are you going to have access to a market? Because you will have access to a global market. You have to compete, and it's actually live. It's extraordinary. I mean, anyone can go in now. And it's a web-based technology, so you can't tinker with results. So if someone orders a commodity that was more expensive, a flag will go to the supervisor, and you can track who made the decision. If you if there's a new, better product that's been through, one of the big problems is WHO makes a recommendation, it takes 15 years for them to get through the regulatory system and down through. If you try to order something that there's a better product and new guidance for, a bubble will come up and say, did you know? And then if you still try to order it, a flag will go to the supervisor. And we can track, we're already seeing 40% reductions in procurement times because you can track electronically where it's at, where the procurement is at, because they sit on desks for 6 months. Yeah. So this is a huge revolution, and what we want to do is flip it up to a global public health good, so it's not just for our commodities, but it's actually for all global health commodities. So anyone who has a commodity can put it that meets quality standards, which is the incentive to invest in quality, because you have automatic access to a market, and then you're in a pricing competition, basically. So we're hugely excited about this, because the answer to your question, Ian, is how do I access a market? And you can't get investors to invest if you don't have a business case with access to markets. Yeah. And in the past system, there was no access to markets because it was impossible to work through country by country, regulatory authority by regulatory authority, monitoring the RFPs. It was impossible. So now there's a tool. We're going country by country. It will take us time to implement. We have 6 countries already in with commodities worth about 70 or a little bit more $1 million, and this will grow over time with more and more countries signing up. And the key thing is countries, and by the end of the year this will happen, will use their own money, not money through the Global Fund grants, to access the system. So then it's their money too, and then you're expanding and expanding and expanding, and that will radically change things. One of the things we're working on is what's the global public health good or goods for the supply chain? What are the off-the-shelf tools that could be useful for countries to have open source access to? It's all open source. So I think these tools that give a market, an automatic market, could be revolutionary to companies to be able to project and to investors to have a projection on what they can do.
Yeah. It would really be good to get the audience take on this, right? Are there any comments or questions that you might have, or different ones?
My question is for you, Mark, Dr. Daibu. First of all, I'm with the U.S. government in Nigeria. I want to say thank you for bringing Chris Game on board and for kind of revolutionizing the way Global Fund thinks about supply chain logistics. And I'm wondering if there's something similar that could be done in the area of financing and getting PRs to utilize commercial service providers, not so much on the supply chain side, because we're doing that now, we're seeing that, but really when it comes to laboratory service provision and healthcare service provision. Would you ever consider kind of growing the mandate? Do you think the board would allow you to do that?
So the mandate around laboratories, around the other pieces of procurement is there somewhat because it relates to healthcare. And you know, what worked in Nigeria is everyone coming together. So USAID is one of the partners, the Gates Foundation is a partner, Gavi is a partner, so everyone came together instead of doing independent things. We'd have to do the same with these other areas because there are investors in other things. But laboratories, absolutely, and diagnostics, absolutely. I mean, we're moving from the treatment to the diagnostic pieces, but there's so many partners that would have to come to the table. So, and then on finance, well, first of all, EcoBank's another great example of a partnership. So in Nigeria, as you know, we're working with EcoBank, and they're going to build the financial management capacity of sub-recipients in communities because it's a good thing to do and because they want to be seen as doing that. So we are actually now building something similar to supply chain to support ministries of finance and implementers to strengthen their financial management capacity. But then we also need long-term finance. So, and again, we're a piece of this. So we're partnering with the World Bank and Gavi and others so that we have a support team around finance. So none of us naturally have people who know how to structure a deal to go from a grant to a loan to a budget line. Theoretically we know, but to actually sit down and do that, we don't. So we're working with the World Bank to bring that capacity in. And we want to link with the private sector, and we actually have some great private sector contacts to help build that capacity as well and to really start structuring deals effectively. So we're getting there, but you know, we're a piece. So I think what we need to do is similar to the supply chain, where we were a piece in Nigeria, is bring the right set of partners together country by country and then see who has the lead and then try to develop that. So thank you for the question. Thank you for USAID's strong engagement, because without that, we wouldn't be where we are with the supply chain in Nigeria.
Hi, Kelly Hamblin, the Senior Supply Chain Advisor for USAID in Tanzania. And my question is for the suppliers. I was wondering if you could speak a little bit to, let's say, shyness about working and entering into a contract directly with the government of the countries where you're operating in or in the region. I thought that the point that you made, Pyramid Varma, about maybe not quite asking for set-asides, but I thought that was really interesting, and the question that I asked myself was, why did you not bid on the contract that the government had put out? Because I think that eventually entities like PEPFAR or Global Fund or others will not be able to continue to be the arbiter between the governments and the private sector. And now is an opportunity to kind of build their capacity. I know there's shyness. I know sometimes they disperse funds late, and sometimes their contracting is perhaps a little wonky. We talked about how public procurement is difficult. That is not unique to Tanzania and other countries. So I was wondering if you could just speak a little bit to what needs to happen so that we don't have to continue to have Global Fund or other entities who will facilitate those public-private partnerships.
Thank you. So you're very right. In terms of, I think when it comes to over long-term sustainability, like I said, I think the government will find it very difficult to implement, for example, testing. For example, now we have to move into viral load. I think it will take a lot of effort for government alone to implement the viral load implementation and to get it working in a shortest period of time. So it will be ideal if the government will stop maybe procuring the equipment, also personnel, and outsource this work to private sector, and also maybe local, all the private sector in Tanzania or in different countries come together for the contract, for example, what you have put in Tanzania, whereby all the private providers, they have gone to the government and asked, they have asked to, sorry.
I mean, essentially what you're saying is you would go the route of outsourced service rather than just buying stuff in. That's the choice of which way do you go. The bit that interests me about the question is, how do you get the risk out of it, out of that relationship? And I think this is where I've got quite interested in these performance guarantee discussions about saying, how do we take aid money and use it to underwrite a relationship rather than to fund a service? And in fact, we've had a very successful experience with the government of Malawi, where we've entered into a direct contract with them, but it's been underwritten by DFID. And so I think there's a really interesting thing for us to explore around those type of financial instruments to get over the shyness, if you like.
Nevin, could we ask your take on this, right?
Yeah.
But also perhaps give us the context in how you see a mechanism to address what is clearly a need for capacity building as well.
Well, I was going
and
to say,
how do you see government's role in that?
Yeah, I mean, from our perspective, we were very willing and eager to engage with every government that is willing to purchase quality ARVs and ACTs from us. The issue is, it is, for a new quality manufacturer, it is incredibly difficult to penetrate. By that I mean, you're starting from, as it were, a standing start. To use an analogy against, running against Usain Bolt, who's running, at full pelt past you, because the manufacturers in India and China and elsewhere have huge economies of scale, and as we know, economies of scale lead to lower costs of production. And if you're a new manufacturer in Africa, you necessarily start off with very low economies of scale. So you're almost, as it were, running not only against to use the analogy again, Usain Bolt from a standing start, but running on one leg as well. It's incredibly difficult to make your products not only of the right quality, but at a price initially to compete with companies elsewhere in the world, particularly in India, China and elsewhere, who, as I say, have these tremendous, long-established economies of scale. And for a company like ours, that took several years to even make some degree of headway. And for a new pharmaceutical manufacturer anywhere else in Africa, I think it will be a similar long haul. And if we do want to address the issue of 98% of ARVs and a similar proportion of anti-malarials being imported and not manufactured into Africa, somehow I would suggest that we need to address that issue. How can we incentivize other manufacturers, pharmaceutical manufacturers, quality pharmaceutical manufacturers, to go where maybe this company has gone in the past?
Sure, yeah. And I guess we're referring to pharmaceutical manufacturers and not packaging companies masquerading as such. Ian, your comment on this? We close to the time, so perhaps some
maybe just some final thoughts then. Maybe something we also have to do. I really like that question about the shyness, because it's given me a completely different. Shy has never been one of my problems. So we've always gone out and gone looking to build these relationships and gone looking at how we can explore in new and different ways. And so maybe what we do actually have to do is to create the fora whereby we explain more to local enterprises what it is we've done and what we've found as success stories and things that have worked for us, in order to encourage other people to get into the game.
I would just add to that two things. One is, and we've made this shift, and we'd encourage everyone to do it, is COGS, our cost of goods, versus cost of delivered goods. So for a long time we operated on COGS, and that was very debilitating to local manufacturers, A to Z in Tanzania being one of them actually. And when we switched to cost of delivered good, that actually became very competitive. So by switching to cost of delivered good, I think we get part of the way there. And the other way, to me, is the access to markets. And that could be volume guarantees. It can be a lot of different ways to do it. But by accessing markets, you can then get investors who will hold that risk. I mean, I think it's really hard for development organizations to pick a product and put underwriting behind a product, because there are lots of products out there. And picking it because you're in that country, to me, is a mistake, because that might not be the best product. There might be a product in the next country or the next country or the next area that's as good or better. And for us to put bets on that, to me, is an error. I mean, we're basically undermining what we should be doing, which is having a competitive market to create the lowest cost, highest quality product. But there are things we can do to at least weight it towards whoever wants to produce, and then play the game and get involved, and that requires going into the competition. But I really worry about development agencies who are not expert at this stuff, even when we have experts saying, we picked this one, and so we're gonna underwrite, because we might be missing a lot by doing that. But there are ways for us to structure things that provide the incentive for investors and provide the incentives for companies to be able to do that, and that conversation is necessary between all the players, including the private sector.
I agree. I think there's clearly also a context in which one has to consider the sort of regulatory systems that are in place, whether they at a regional level or at a country level, that would facilitate this. And so there's a very strong capacity building component, I would think. Let's take the one.
I think that something Mark said about setting up WAMBA seems to counteract the need to improve and increase local manufacturing. I think my personal view is that we should be moving towards a fair trade model of local manufacturing, because we need to think about how do we engage countries to to improve local manufacture of drugs. The other thing also is that when we talk about the improvements that you've had with procurement, improving the procurement process, what of the last mile delivery? Is that not the place where the private sector should be looking at? While so that you don't undermine government systems, you don't undermine government health systems and procurement systems. But the private sector should be looking at last mile delivery to ensure that this boom and bust in many countries is eliminated. Thank you.
Could I ask you to reflect on that very quickly?
Yeah, I think last mile delivery is possibly the place where we can do the most as the private sector.
Correct.
The great economies of the world were built off the back of small to medium enterprise. And if you're a small operator, a small business person, you need to be able to get product to your business and get your product back to the market. And so if we don't build logistics enterprises that get down to community level, we're not actually responsible for big D development. So doing the last mile needs to become a fundamental of what we are about in these markets. If all we're doing is the easy big volume stuff, we're not really making a major difference.
Yeah. So I guess there's ample opportunity to continue these discussions at the conference. So I'd like to ask you to please join me in thanking the panel and of course yourselves for quite an engaging discussion.
Sorry.